Hi, I'm Roby Perissin at MGC Diagnostics. Today we're going to deal with a brief yet complete introduction to Forced Oscillation Technique or Oscillometry, and specifically with the device Resmon Pro Full V3. Let's get started. Here is the introduction to Forced Oscillation Technique or Oscillometry, specifically using the device Resmon Pro Full V3. The program of the seminar is quite straightforward. We're going to be talking about what is FOT and what the Resmon Pro Full V3 does with oscillometry, what it measures, the two main parameters, the central and peripheral components of airway obstruction, the exclusive expiratory flow limitation that can be measured and quantified with Resmon, what the latest oscillometry technical standards or guidelines from 2020 have done to make this measurement so popular as it's becoming today, the clinical solutions of oscillometry, so asthma, COPD, evaluation of airways clearance techniques, and the new post-COVID patient testing, two niche applications such as the use of FOT with exhaled nitric oxide and how to use FOT in the bronchial hyperresponsiveness testing, a quick section on running a measurement including patient posture, the procedure for a correct measurement, and how to evaluate and interpret the test, what educational and support material we make available, and last but not least, a very quick demonstration of a oscillometry test. Let's now go with the history and theoretical basis of oscillometry with the Resmon Pro V3. Oscillometry is not a new method. Everything has been written, everything has been published, everything has been validated about oscillometry. However, it's been restricted mostly to non-cooperating subjects, which is really what has really changed today. The technique dates from the 1950s. It's called forced oscillometry because it's based on a large loudspeaker that sends into the patient airways a signal, some waveforms, some acoustic signals at different frequencies. It was developed to overcome the inevitable issues with the gold standard, which is forced spirometry, to which a few issues have been found in the past years. First one is the need for the deep inhalation that precedes the forced expiratory maneuver that causes in asthma and COPD a hysteresis of the lung, which has an unpredictable effect of bronchodilation or bronchoconstriction. Also, the forced maneuver is not easy, not simple to do, especially with the ATS-ERS standards to consider a maneuver acceptable. And also, the measurement of FEV1, it's a representative of airway obstruction, but with the lung under a certain stress and after a deep inhalation. So the FOT measurement is really sending sound waves down in the lung and seeing what comes back, and that will allow us to detect and localize the obstruction at either central, peripheral, or heterogeneous. And what you see now in the figure is what the patient will feel, a slight vibration over his normal tidal breathing. The frequencies are sent overlaying the normal tidal breath, so they are much faster than the tidal breathing. This is exactly what happens with the large loudspeaker, which is needed. This is what the original technique always used, and it's very needed to have a large loudspeaker to generate these waveforms or this sinusoidal signal that imposes to the normal tidal breathing. So what we're going to look at, several frequencies that are sent down in the lung. We use a multi-frequency approach with three frequencies. The low ones travel farther in the airways and reach the peripheral airways. The higher ones are more sensitive to central airways, and the highest ones look at the whole lung. So that way we can actually look at localize the obstruction in the different components. FOT-Oscillometry has made giant steps in the last few years. If you look at the number of publications that are now coming out every day there is 1 or 2 publications at least, you see a very steep increase, especially in the last 4 or 5 years. And this is because since the guidelines came out at the end of 2020, considering 2021 as a break year because of the pandemic, now we're beginning to really get a lot of interest and a lot of traction on oscillometry, with thousands of papers published, and with the technical standards that have gotten spirometry closer to oscillometry, or better, oscillometry closer to spirometry, requiring, like for spirometry, 3 acceptable oscillometry tests, with a very big difference. That to perform 3 acceptable oscillometry tests on even the sickest patient, it will always take less than 5 minutes, when we all know how long it may take to get 3 reproducible good forced spirometry from a sick patient. So some of the latest publications have actually confirmed, for example in 2020 by the European Respiratory Journal, that the clinical applications of oscillometry are wide. They validate further the tidal expiratory flow limitation index that Resmon provides. And last but not least, they confirm that the terminology is now becoming very much understood by all clinicians. So before we proceed any further, what is the Resmon Pro Full, which is now one of the most popular oscillometry devices today? Well, with the latest technical standards, as I was saying, Resmon can now be used on all patients in normal clinical practice, as well as, of course, for research purposes. So Resmon can be defined as a device that enables the user to get, with a few accepted breaths, from small children to adult, precise detection and localization of pulmonary obstruction at peripheral, central, or heterogeneous. Also, it features the exclusive parameter, well recognized by all societies and well used in clinical trials, of the tidal expiratory flow limitation. So the predicted values are available for all age ranges. From an age of 2 to an age of very elderly, we have a choice of different reference values performed with oscillometry, and many of the latest ones specifically with the Resmon Pro Full. What does the FOT method measure? What do we measure with Resmon? Well, 2 main parameters. Resistance of the respiratory system, RRS, it's really the representation of the airway caliber behavior. When reactance, XRS, it's really indicative of the amount of air that can ventilate the peripheral airways or the distal lung. So, to speak spirometry language, resistance will actually measure central airways obstruction like FEV1 does. Of course, can't compare them exactly because FEV1 is performed dynamically and involving a stretching of the airways, when resistance of the respiratory system is performed in normal tidal breathing. It can be measured at different frequencies, and in that case, as you see from the figure, when you will look at the slope of the resistance at low frequencies and the resistance of high frequencies, if this slope is very pronounced, that is indicative of heterogeneous obstruction. In fact, it's called the heterogeneity index. Resistance is very easy to explain, as you can see from the photo, pre and post a bronchodilator, and it can be used now in clinical uses with predicted normal values. Now, resistance of the respiratory system is actually something that is taking over resistance with the body box, or resistance of the airways, or RAW, and it's much simpler. It requires less cooperation. It has the same variability as the resistance of the airways, but also more important is more sensitive to central and peripheral obstruction than a resistance of the airways. Reactance, on the other hand, XRS, it's really how air reaches and ventilates the small airways. So if we want to look at it, at the behavior, it falls below the predicted value like a very important parameter of spirometry, but very difficult to obtain is, which happens when you have peripheral obstruction, presence of tidal expiratory flow limitation, or alveolar gas trapping. And in terms of population, reactance goes below the predicted values when you have a stiff lung, neuromuscular patients, when you have obesity, pregnancy, and so on. So, to make a long story short, reactance can be compared, not in the same conditions, of course, but to measure small airways like FEF 5075, so looking at the last part of the forced expiratory maneuver, which is the most difficult to represent, can do. So the two most important parameters, whether we measure a single frequency or whether we measure multi-frequency, is always the resistance and the reactance at the lowest frequency measured, 5 Hertz for adults and now for children as well. The reason being that the 5 Hertz travel and seize the whole lung all the way to the small alveoli. Another special thing that we can do now in oscillometry with the Resmon Pro is to measure the within breath parameters, inspiratory and expiratory, that leads to measure tidal expiratory flow limitation. That way we can detect and quantify tidal expiratory flow limitation, which is when your patient, if it could do a spirometry, the tidal breathing loop would touch the expiratory limb of the forced loop, and that would cause inevitably, very often, a phenomenon of hyperinflation or changing lung volumes. So, as you can see from this slide, the bottom right, this is what happens in hyperinflation, is the patient increases its tidal, its functional residual capacity. So there is a patented index, which is basically the calculation of two measured parameters, the inspired and the expired reactance, so the small airways, at 5 Hertz. When this difference is higher than a threshold that has been determined and validated in literature for many, many years, you are in presence of a tidal expiratory flow limitation that, as you can see from the figure, can be quantified as flow limitation percentage before and after a treatment, or over time to, for example, to track changes in rehabilitation. The resistance, the inspiratory resistance, it will always be measured with all the alveoli opened, because the alveoli are kept open by the negative pressure inside the chest. When during expiration in disease state, many of the alveoli will not communicate and will not be reached by the frequencies because of the choke points that the positive pressure causes into the small airways. One of the many validations shows how in extremely flow limited patients, before and after a bronchodilator, if you look on the left side and looking at the total resistance, which includes the expiratory side, there is hardly any change. When very often when you look at the inspiratory resistance, so when the alveoli are always open, the true lung, you will see a significant change. Let's now talk about the latest technical standards for respiratory oscillometry in 2020. What changed after that? Well, that was a milestone because, again, the technical standards brought oscillometry to the same level as spirometry. As spirometry needs 3 repeatable force maneuvers, oscillometry requires 3 repeatable oscillometries, which are much easier to measure. And what's very important is that there are coefficient of variation, so an index of variability that can be used, and the device will actually tell the operator if it has been reached, which is 15% for pediatric patients and plus or minus 10% on adult patients. What's most important, and that allows daily clinical use, is that now there are thresholds for significant response to treatment. And that has been set to a decrease of 40% in resistance and or an increase, so a more efficient reactance, so 50% for reactance. That also has been well validated, well documented, and it's used in clinical practice. So, what patients can or should be tested today with oscillometry? The answer is very simple. Today, after the launch of the ERS standards, we can test all patients, not only the non-cooperative. And that can be in pulmonary departments, including post-COVID patients. It can be in pediatric departments, including in the field. It can be in respiratory and neuromuscular rehabilitation, thoracic surgery, and during physiotherapy, so with patients less cooperating. In asthma, so respiratory allergy for adult and pediatrics. In occupational medicine, including taking the devices in the field, at the workplace, because of the ability to test even when the patient does not want to perform a good spirometry. And last but not least, to follow patients with cystic fibrosis, where the main outcome is the buildup of secretions in the lung. Let's talk a few words about the many patients that cannot be tested, or because spirometry is contraindicated. And here in the slide that you can pause and look, we will see the many conditions that we have taken from the different guidelines, AARC, BTS, ATS, ERS, that list real patient conditions where spirometry, forced spirometry is contraindicated. If you put together all these patients, that makes a large quantity of patients that today we're not thinking about testing with forced spirometry because we never had the chance. We can do it now with oscillometry. Let's look at the clinical solutions of and the uses of FOT in the main applications: asthma, COPD, evaluation of airway clearance techniques, and post-COVID. The 5 clinical solutions for these uses are very simple. Spirometry is a very hard test to do, and the solution with FOT, it's an easy and fast test with few tidal breathing maneuvers to identify if there is an obstruction and to localize it. The pre and post treatment, again, it follows the first point, very difficult to perform for many patients, especially COPDs or especially children, and we can now do with a fast, easy to perform test, the pre and post bronchodilation test, which will save also a lot of time. The deep inhalation effect that we discussed earlier has no issue with oscillometry. The determination and quantification of tidal expiratory flow limitation is possible now, and last but not least, the use in the evaluation of airways clearance techniques. So the physiotherapy that works on a patient for half an hour removes an obstruction. How well it's been removed, how efficient was that maneuver? Let's specifically now look at the evaluation of airways clearance techniques. Well, physiotherapy is an art. And physiotherapy is done on a patient to reduce pulmonary resistance, to expand the collapsed pulmonary areas, improve respiratory function, and reduce the obstruction. All items that can be addressed with a simple oscillometry maneuver. And there are plenty of uses and validation using in pulmonary rehabilitation the expiratory flow limitation maneuver and the inspiratory parameters that are more important in the results evaluation. That is, for example, what we're showing here is an important work done on adult cystic fibrosis patients. Let's look now at the post-COVID patient evaluation. Well, post-COVID, it's definitely with oscillometry safer. There is less particles being dispersed in the room with tidal breathing maneuver. But now that COVID is at least somewhat behind us, not completely. What's more important is that FOT is sensitive, more sensitive than spirometry, especially for small airways testing. So for patients with, for example, pneumonia, double-sided interstitial pneumonia, what will be the issue will be very often the small airways and the hyperinflation. So we have clinical cases of patients. This is a good example that you will see in the green area few months before the onset of COVID. onset of COVID, the first month when the small airways really went down, then an increase in the yellow area, that was during oxygen, and then following the patient for another 6 months to just verify that the patient goes back to normal lung volumes and normal small airways function. This is one of the trends that are available with the Resmon Pro Full V3 device that shows the same thing. You see the drop in reactance, the increase in reactance, and then the slow improvement over the next months. Let's now talk about using FOT with FeNO, exhaled nitric oxide, in asthma management. Well, two main uses. Both FOT and FeNO are very strong biomarkers. FeNO for eosinophilic inflammation, and FOT for obstruction. What's important is they are both very effective even when the patient has no symptoms, or when if a spirometry is performed is normal. And asthma, as we know, is a nasty disease, especially mild asthma, because some days the patient feels good, some days the patient doesn't feel good. So that is something that you can do together, FeNO and FOT. But also when you have prescribed a medication, during the controls, you can actually check the patient for compliance to therapy by looking, for example, in this graph, the resistance in the upper left corner that went down for the last 2 years, the reactance that went up, the FeNO that went down, and spirometry that is not as sensitive, stayed stable. But look at the last part of each graph, there is a worsening. And that is because the patient did, as very often they do, they stopped the medication because they felt good. So that is another big application of using combined FOT and FeNO. A few words on using FOT in bronchial hyperresponsiveness testing, so methacholine, for example. Well, the scientific societies have validated the thresholds. So for adults, the threshold is a 35 to 50% increase of resistance. And for children, it's 35 to 40% increase in resistance. Better, if possible, to use inspiratory resistance to eliminate the eventual issue of the laryngeal constriction, which is what we can do with the Resmon Pro. So the protocol of bronchial challenge is exactly the same as you would use with spirometry. A baseline test, and then methacholine or whatever agent, oscillometry, methacholine, all tidal breathing with a greater comfort for the patient, a much faster testing for the operator. At reaching the threshold, as you see in the right side of the image, that was determined, you perform simply a normal bronchial reversibility as you would do with spirometry. Obviously, there are many papers or validations that the FOT can help really facilitate the diagnostic assessment of asthma, and it can be used with different agents, including mannitol testing, where FOT was very helpful and suitable for use in bronchial challenge. Let's now go to the running a measurement with the starting from the patient posture. Part of our educational material that we have developed is a quick 5 steps guide according to the guidelines to perform the recommended testing procedure, so that the physician or whoever interprets it has a very nice, good test. And that will involve checking for correct posture, checking for the measurement quality, the single first measurement, including a low ventilation, a quiet breathing patient, performing a second and a third measurement, and then it becomes a session. Evaluate the results, seeing if it's outside of the normal values or not, performing eventually a treatment, and evaluating the response to treatment. So comparing a pre to a post session. The recommended test execution is with the patient with their hands falling, their arms falling around the body, and an operator therefore making the shoulders relaxed, with the patient in the back slightly holding the cheeks and the soft area of the chin. Or if the patient does it on his own, the patient can hold the cheeks on his own, keeping slightly the elbow spread. This is the correct posture that you can see with the patient with the hands falling around the body and the operator in the back holding the cheeks. The evaluation of the test, it's actually now very simpler than we thought. It is important to remember that now that we understand that oscillometry measures simply central and or peripheral obstruction at tidal breathing better than spirometry, you can use oscillometry exactly the way that you would use spirometry. So in the picture, there should be patient clinical history, symptoms, results from other diagnostic tests, and then oscillometry, exactly as you would use spirometry, because oscillometry can detect and localize central and or peripheral obstructions, and patient responding or not with the thresholds, with the published threshold, to therapy, and detect abnormalities present only during normal tidal breathing. The educational support material that we supply, it's the new quick guides that I just mentioned, the publication list, the seminar that we perform in live or Zoom, and the results evaluation poster. So here we go with the publication list, indexed by subject, that you can request anytime, and it's kept updated with the many new publications. The seminar called the Demystifying FOT, the basis, the parameter, the clinical and research application in the different uses, and the bibliography update. Again, this is available by Zoom or in person. And last but not least, the poster that we have developed in several languages that basically will help the operator to look at the test evaluation, the localization of the test, and the quantification of the expiratory flow limitation. To close now, we're going to perform live a FOT measurement with the Resmon Pro Full. Notice that we already have performed 2 measurements. So now we are facing a session. We're going to perform a third one. We are going to check that the results are repeatable. We're going to perform a third one. We're going to analyze the quality of the session, and we're going to evaluate the result. To end the introduction to oscillometry or forced oscillatory technique, we're going to now perform a measurement, which is the third or the fourth actually of a session. So the system will actually give us a quality control for the repeatability of the session. The system has been verified for proper calibration in the morning with the test object, which verifies it for both resistance and reactance. The device is ready to go. I am going to now ask the patient with his arms along the body, so the shoulders nice and relaxed. I'm going to ask the patient, I'm going to start the test and ask the patient to breathe normally. I'm going to delicately hold his cheeks so that they won't flutter, and the soft part of his chin. And you will notice now that the device will do a countdown on the bottom left corner, -3, -2, and -1. Those are called the adaptation breaths. So the system lets the patient get used to the slight vibration. We're looking at real time at the tracings from top to bottom of flow, resistance, and reactance. But most important, on the right-hand side, the tidal volume, the ventilation, the resistance, the coefficient of variation within this measurement, the reactance, and in real time, the expiratory flow limitation, particularly useful for COPDs. So at any moment, you see, oh, these are all accepted breaths. At any moment, should the patient cough, okay, or close glottis or remove from the mouthpiece, you see that those breaths were excluded. And the system starts counting only when good, repeatable, physiologically valid results are acquired. So we are now at breath number 9, and the test automatically ends at breath number 10. Of course, the end of test can be selected in number of accepted breaths or in time, like 1 minute or 2 minutes. So we have finished the test now. We can look at the screen. we look at the ventilation and the tidal volume are in green, the total resistance, the total reactance, the coefficient of variation, and the flow limitation. So what we're going to do now in the evaluation process, if one wishes, is to look at the coefficient of variation that I'm going to show you now with the arrow in the little box there. The coefficient of variation is 3% over the chosen 3 measurements over 4. So this was the 4th measurement. We let the system decide which one are the best 3. So I selected the 1st, the 3rd, and the 4th. We look at the left-hand graph of the resistance at 5 Hertz, and we can see inspired, expired, and total. They're all below the predicted line and well below the upper limit of normality, that being the predicted normal range. And on the right-hand side, the reactants, inspiratory, expiratory, and total, are well below the predicted line and well over the lower limit of normality. You can see on the upper right corner that the patient does not have any tidal expiratory flow limitation. We go to the multi-frequency graph and we see the 5, 11, 19, so the multi-frequency graph well below the resistance, well below the upper limit of normality, and the reactance well above the lower limit of normality. As a check, according to the guidelines, we look at the ventilation, which is 8.7 liters per minute over the 3 accepted breaths, so well below the 18 liters per minute, the 3% of coefficient of variation, and just as a curiosity, we're going to go on test number 4 and hit the little pencil here, and we're going to see a nice interesting feature of this system, which is showing us the last test that was performed, and you can see very clearly the excluded breaths, which were the breaths where the patient had coughed. So if we readmit manually those breaths, look at what happened to the coefficient of variation. It goes well outside the acceptable range. So we can actually exclude these breaths or any breaths we want, or we can let the device do its own calculation with a little circle that you see on the center. The system will actually do itself the calculation of the best tests, the best excluded and non-excluded tests. So now we're going to go back. We're going to look at the results and the coefficient of variation of the 3 accepted tests that, as we saw earlier, is well below the acceptable range of 10% coefficient of variation. So it's and we are going to look at the results, the numerical results, if we wish, hitting the little tablet on the top. And here we can see that the z-score column, very important, it's all in black, so it's not in red. Should any of these parameters be in red, that means that these parameters are outside the normal range and we would need to do a treatment and therefore evaluated. So we're going to go back now to the measurement menu, and this is really all that needs to be done. We've shown you with this introduction to oscillometry the basis of oscillometry, the parameters that are measured, which are very simple to evaluate: resistance and reactance, central and peripheral small airways obstructions. We can localize where the obstruction is. We can detect and quantify tidal expiratory flow limitation, which is a very interesting and useful parameter in COPD and severe asthma and for rehabilitation. We have shown you the correct patient posture. We have shown you how to perform the 5 steps of the 5 simple steps of a correct quality measurement that will allow whoever interprets it to have solid, robust data. And we've shown you how to evaluate the session, which is nothing different than using spirometry. So considering patient history, considering symptoms, considering other diagnostic tests that are all part of the picture, and adding, as you would do with forced spirometry, oscillometry, all guided by the approved international technical standards. So, for more information, to receive the educational material, pricing, see the product in a demonstration, please write on these slides that we're showing you now write or call the numbers of our US headquarters or our international headquarters. And with this, I want to thank you for listening in, and I wish you all a very good day. Goodbye.